We are Physicians Together with Vulnerable Canadians. Thank you for joining us today. We are a grassroots initiative of physicians that are concerned about the changes that are happening in legislation. Firstly, we thank MP Tamara Jansen for hosting us today. Would you like to say something?
I just want to say that it's an incredible honor to be able to host, make sure that you guys could be here, that your voices could be heard, and the voices of the vulnerable whose voices have been marginalized. So I'm really glad, and especially because it's November, which is Indigenous Disability Month. So thank you so much for being our host like this.
Thank you. My name is Dr. Ramona Coelho, and I work in London, Ontario, and I care for marginalized persons. And we're here to bring forward the voices of the disability, Indigenous, and medical specialists who have not been heard so far in this debate. Go ahead, Leonie.
My name's Dr. Leonie Herx. I'm a palliative care physician from Kingston, Ontario, and I'm also an advisor to the Vulnerable Persons Standard. The Vulnerable Persons Standard is an internationally recognized, evidence-based framework that provides clear and comprehensive guidance to lawmakers by identifying the safeguards necessary to protect vulnerable persons in a regime that permits MAID. We'd like to introduce our first speaker, Mr. Tyler White. Tyler White is the CEO of Siksika Health Services and the president of the First Nations Health Consortium. Tyler has served as an analyst, negotiator, and manager for the Siksika Indian Self-Government Process, executive director for the Calgary Indian Friendship Centre, and the Siksika Health and Wellness Centre. He is a past winner of the First Nations Health Managers Award of Excellence. Above all, Tyler is committed to strengthening and advocating for the health and well-being of Indigenous people and communities. Go ahead, Tyler.
Thank you.
Hear me now?
That means good morning in our language. It's an honor to be here. And again, my name is Tyler White. I'm the CEO of Siksika Health Services, and I've been in this role for the better part of 22 years now. And I'm happy to offer a few words on behalf of our nation and on behalf of our organization. So I have a statement that I'm going to read, and please follow along. So on behalf of Siksika Health Services from Siksika Nation, Treaty 7, and Blackfoot Confederacy in Alberta, we have grave concerns over the implications of Bill C-7 on our Indigenous community. The expansion of medical assistance in dying beyond those whose death is foreseeable will have a lasting effect on the Indigenous populations in Canada, who suffer from greater health inequities than non-Indigenous people in areas of life expectancy, rates of chronic diseases, disabilities, mental illness, chronic pain, and access to health services. Indigenous peoples also experience higher rates of poverty, food insecurity, and unemployment, all negative social determinants of health. Let us be clear, MAID, with its administration of a lethal substance with the intent to end a person's life, is counter-cultural to our Indigenous culture and practices. Our concept of health and wellness does not include the intentional ending of one's life. We recognize the dignity from its beginnings to natural death, and efforts to suggest to our people that MAID is an appropriate end to life is a form of neo-colonialism. Extraordinary efforts have been made in suicide prevention in our communities, and the expansion of MAID sends a contradictory message to our peoples that some individuals should receive suicide prevention while others suicide assistance. Our consistent message to our youth has been that suicide is not the answer to the difficulties and challenges we face as people. Bill C-7 sends a conflicting message in direct opposition to ours. Another grave concern for Bill C-7 in its current form is the absence of protection for individuals working in our communities who do not wish to participate in MAID. We believe that our people should not be coerced to participate in non-Indigenous practices against our conscience and will and it is the kind of oppression that has been the source of much trauma in our history. The Truth and Reconciliation Commission of Canada calls upon those who can effect change within the Canadian healthcare system to recognize the value of Aboriginal healing practices and for respecting Indigenous people's right to self-determination in spiritual matters, including the right to practice our own traditions and customs. Bill C7 should be amended such that those who opt to abstain from participating in MAID directly and indirectly will be protected to do so without discrimination in their employment in the healthcare system. We are a resilient people and will continue to advocate for the health and wellness of our community, as well as the right to self-determination in exercising our cultural practices and traditions. Thank you.
Thank you, Tyler. Our next speaker is Dr. Thomas Fung. Dr. Thomas Fung is a physician lead for Siksika Health Services on Siksika Nation, where he has been a family physician for the past 13 years. He also has a care of the elderly practice in Calgary, where he manages residents in supportive living and long-term care. Welcome, Thomas.
Thank you for having me. I would like to take the opportunity to bring awareness to the challenges of practicing medicine in First Nations and remote communities, where patients don't receive equal access to care as in the city. To illustrate this with an example from Siksika, I have a patient who suffers from interstitial lung disease, which causes him to be short of breath, even with simple tasks such as going to the washroom or going to the kitchen to get something to eat. He has poor mobility, requiring the use of a walker, and he cannot walk for more than 2 minutes without gasping for breath. His stamina will improve greatly with home oxygen, but regretfully, his lab values on testing falls just short of qualifying for funding through non-insured health benefits for First Nations. Without funding, his family does not have the finances to afford oxygen. There is no cure for his disease, and he is increasingly tired of living. His only choice at this time is to wait until his condition deteriorates. Now, under Bill C7, this patient would qualify for MAID, but what I would advocate that what this patient needs the most is home oxygen for a better quality of life, and not assisted death to end it. Going further, it would go against one's conscience to administer MAID to him, knowing that there are other ways to relieve his suffering that are available but haven't been tried. If I was to arrange psychiatric consultation, it will take me currently upwards of 8 weeks for that to take place from our rural community. Add to that another 6 or more weeks to optimize medications, the 90-day waiting period is not enough time to give this patient the help he needs. And I would argue not enough time for a lot of chronic conditions. All that is to say, Bill C7 should be amended to include as a requirement appropriate trial of therapies aimed at relieving suffering, such as management from a palliative care physician, psychiatrist, pain specialist, physical medicine, and rehab specialist, for example. Social determinants of health, such as finances, housing, and vocational training should also be addressed prior to qualifying for MAID. Assisted death should be an option of last resort and not the path of least resistance for the vulnerable and disadvantaged. Conscience protection is needed in this bill, as no one should be forced to participate in the intentional death of another person against their goodwill. Thank you.
Thank you, Dr. Fung. I also think we missed introducing another one of our hosts, Michael Cooper, who is actually from the Justice Committee. We thank you very much for being here and supporting us in this endeavor.
I'm now going to introduce the next two speakers, Spring Hawes and Gabrielle Peters. Spring will be presenting both of their statements. Spring Hawes incurred a spinal cord injury 15 years ago and is a tetraplegic. Since then, she has been an entrepreneur, an elected official, and is a board member for a large peer group of wheelchair users. In her public life, she has been outspoken on the rights of women and marginalized and disabled people. She is passionate about working to ensure all people live well and envisions a world that embraces diversity and fully includes all people. Gabrielle Peters is a disabled writer living on one of the country's lowest incomes in one of the world's most unaffordable cities. She uses the isolation and exclusion imposed on her by poverty and inaccessibility to reflect on those and other things. Her words are informed by the work of disabled activists, writers, thinkers, and scholars past and present. Spring, please go ahead.
Thank you so much for the introduction. And good morning, everyone. As I was introduced, I became disabled 15 years ago through a spinal cord injury. And while paralysis and its complications are by no means easy, I've found that the challenges that are presented by society are far more damaging and difficult to deal with. Every day, as a disabled person, I'm forced to reassert my autonomy and my competence and my humanity. I experience aggressions on the micro level daily when it is assumed that I can't speak for myself or that the clothes I've chosen are inconvenient for someone, or when it's assumed that I will run over your child with my wheelchair when you come upon me on the sidewalk. I've experienced these aggressions on a macro level as well when health concerns have not been taken seriously and were allowed to become life-threatening, or when I had friends who felt sorry for the husband who was leaving me because I was a burden. I'm a rebellious and stubborn person, and I have a supportive family. I have access to money, and I'm white. And all of these things combined give me the resources to continue to fight for dignity as a disabled person. But the fight is exhausting and continuous. It doesn't stop. I will share the story of a young man I met recently who was in rehab for a spinal cord injury. This boy was a student. He was a young athlete in the peak of his physical prime, and he was trying to come to terms with this newly acquired life-changing injury. We can't even imagine, I think, how difficult this would be for someone at his stage of life. I could see that he was struggling, and I asked if he would like to talk, and he agreed. And he shared with me that he was depressed. And now he wasn't depressed. He told me he wasn't depressed because of the disability or the injury. He was afraid that his attitude wasn't good enough and that he was letting the people around him down. So this young man had already internalized that messaging that his well-being was less important than the comfort of the people around him. As disabled people, we are conditioned to view ourselves as burdensome. We're taught to apologize for our existence and to be grateful for the tolerance of the people around us. We are often shown in many ways that our lives are worth less than non-disabled people. And in this context, in this milieu, this societal position, our lives and our well-being depend on us being compliant, on being agreeable. And choice is not a free choice when our lives depend on being compliant. That's the end of my statement. I will read for Gabrielle Peters. My name is Gabrielle Peters. I'm disabled. I'm poor. I'm poor because I am disabled. Picking who will be poor is a function of society. Bootstrap is a lie. I didn't choose to be poor. I wasn't given a choice. Politicians say if disabled people don't want to be poor, we should get a job. Science-based physicians say that's not possible. If the state offers me the choice to die, but not the means to live, who is really making the decision? I think that this is where I'm supposed to tell you my disability story, including the part where a healthcare professional sat at my bedside and urged, and then almost insisted that I take her up on the consoling prospect of forever rest. After my partner announced he was leaving me because I was too much of a burden and I no longer fit into the life that he wanted. My story is long and complicated, but what matters most about my story when discussing policy is that my story is part of a larger story. My story is a part of Canada's story, and this country's story is a part of mine. Canada is racist. Canada is ableist. Canada is sexist. Canada is no stranger to injustice. We can debate numbers and causes, but we can't debate the existence of these things or their impact on individual humans and the choices they face, or the way these will be woven into their stories. This may come as a surprise, given who we tend to see represented, but not all disabled people are white or wealthy. The intersections of class, race, gender, and other axes of oppression dramatically alter the lived experience of a disabled person in this country. This is nonfiction. This is fact. It is what we need to discuss when we talk about Bill C7. The story supporting C7 is fiction, carefully branded, carefully crafted narrative. The state isn't paying hospitals to euthanize, just to assist people to cease breathing. Once upon a time, in a special land called Maine, free spirits flit about, unaffected by the humans around them, unaffected by history, by policy, by codified isolation, by systemic discrimination, by multiple layers of oppression, by the indignity and violence of poverty. They're never blamed or shamed for their bodies or their minds, never judged for their cost benefit, never told their needs are too difficult, too expensive, too much of a burden, never made to feel less human. In this special land, they get only the best care that fits their needs. All bias and hate are poofed away by putting on a white coat inside a building in a bubble topped by a halo that is always fully funded, where staff are always fully rested, and life is always as it should be. Policy should not be based on a fairy tale. So here's my choice. I pick livable income. I pick fully funded supports. I pick free education. I pick truly affordable and genuinely accessible home and community. I pick living with dignity. When is that bill's first reading?
Spring Eye, thank you so much. And Gabrielle. Our next speaker is David Shannon. David is a Canadian disability human rights activist, lawyer, author, and adventurer. After a devastating spinal injury in a rugby scrum at university in 1981, he was rendered quadriplegic. Subsequently, David finished a Master's of Law at the London School of Economics, and he continued in his law practice and non-government organization leadership since then. David's cross-Canada tour in 1997 gained national media attention as he became the first quadriplegic to trek across Canada in a motorized wheelchair. And in 2009, he set another first by going to the North Pole, celebrating the message that seemingly insurmountable barriers can be overcome. Shannon has won numerous prestigious awards and honors, such as the Order of Ontario and the Order of Canada, for his work advancing the rights of disabled persons and other minority groups in Canada and abroad. Welcome, David.
Thank you very much. I'm here today to call for a rethink of the end of life legislation and ask for the safeguards of due process to be included. The central question before Parliament, expectedly soon the Senate, and indeed our country through this legislation will be: where does the empowerment found in the assertion of autonomy end? And where does a subtle form of benign oppression that says your life is less important than mine, even if that means your death, begin? It is my opinion that the proposed legislation creeps over the line of dignity, diminishing its importance. For several weeks after my accident, as you heard, a spinal cord injury that left me paralyzed from the neck down, I lay in bed close to death more times than I wish to contemplate. While faced with that impending reality was an understanding that most of my body would not ever again move the way it had just a short while ago. I had lost mobility, liberty, sense of purpose, and now bedridden in a hospital, all autonomy. Emerging, and many may find this paradoxical, was an eagerness to embrace life in the multiplicity of its rigors and joys. I also had the benefit of profound love and support in my life during the early days after my injury. As I proceeded through rehabilitation and then a career in nonprofit or non-governmental organization, and also a law practice focused on human rights and health law, I have seen that my story is not the same for far too many people facing tragic circumstances and catastrophic injuries. Indeed, all too frequently, I observe that in the face of broad discrimination and barriers, my disabled peers and clients seriously contemplate suicide. And that is due to environmental rather than physical maladies. Should the person trusted most with an individual's health right after a serious injury or illness, and by that I mean the specialist who is saving their life, were to then advise, without prompting, that medical assistance in death were a rational next step, the limits of autonomy and liberty would be subsumed by an implied promotion of assisted suicide. I mean, it's very important. It becomes an implied promotion of assisted suicide. This is particularly true if death is not reasonably foreseeable. The proposed legislation is a bridge too far. It will send the clear message: you may kill yourself and we will help you. Our legal system has been founded on fairness and due process for all with equal measure since time immemorial. This legislation ignores those core constitutional principles developed over centuries. Bill C-7 creates at best a denial of constitutional norms and at the worst, rationalized expediency resulting in the extinguishment of life. We cannot get this wrong. The consequences are too high for our country and for the individuals whom the law will impact. Thank you.
Thank you very much, David. I'd next like to introduce Dr. Natalia Chakova. Dr. Chakova is a physician in physical medicine and rehabilitation. After 15 years of university education in Canada, she's enjoying a busy practice in Kamloops. Her practice includes caring for patients with a range of impairments from stroke, brain injury, nerve injury, to spinal cord injuries. 5 years ago, she started a research project in Winnipeg, interviewing individuals who had spinal cord injury and asking them about their lived experience with suicidality. Go ahead, Dr. Chakova.
Thank you very much for this opportunity. I just want to double check. Can you hear me okay?
Yes, we can.
Thank you. Okay, so good morning. When I started my project 5 years ago as a resident doctor in training, I didn't envision how pertinent it would become to the present MAID discussion. I was inspired by a friend I met in medical school who had had a spinal cord injury. When I asked him about his life, he invited me to go out in a wheelchair with him in Vancouver. It was eye-opening to experience this and talk to him, but I also realized we aren't really taught the actual patient perspective in medical training. This further inspired me to individually interview 23 people from different walks of life who have had spinal cord injuries. I discovered that most of the people I interviewed told me no one had ever really asked them in this amount of detail the dramatic changes they underwent psychologically, and the focus usually in the hospital was on the obvious physical changes. Most of the participants said there was actually a disconnection from medical care staff and really understanding what they were going through. If they had some relatability, it usually came through peer mentors, meaning people who had already had a spinal cord injury and had come to visit them in the hospital. In my project, what is very important to realize, especially for MAID, is that the majority of people who had a spinal cord injury considered ending their lives early on once they realized they were paralyzed. However, what is interesting, and it was a large point to my project, is that every single one of my participants said that in that early time frame, they wouldn't have been able to make an informed decision to die, even though, as mentioned, most of them actually did have some suicidality and in some cases suicide attempts. My participants stated to me they realized they couldn't experience the context of their life without rehabilitation, integration into the community, and having the opportunity to reframe their views on themselves and their life. For example, one of my participants said what helped him the most was a peer mentor who came into the acute hospital and basically normalized his experiences, saying, don't worry about the suicidal thoughts. We all have had them. They'll go away. Just keep pushing. And my participant said just having that landmark, knowing there was something else to come, gave him the steam to go through rehab. And many years later, this participant is enjoying a good quality of life with no intention to die. Overall, my participants emphasize the importance of autonomy to decide what happens to their bodies, including when and how they may die. And that is also something I believe is important. But my participants noted they really needed to understand their adjustment and condition to actually be informed on that decision. Through my research and clinical experiences, I also know how important it is to support patients with rehabilitation access, encouragement, and societal adaptations to enable non typical able bodied individuals to thrive and have a strong place in society. That goes hand in hand with ability to live and thrive in our society. Uh, Overall, thank you for giving me the opportunity to highlight my research and what I consider to be the lived patient perspective as the expert perspective. I think this is very important to highlight for Bill C7, and meaning access to rehabilitation, community support, and patient relative counsel needs to be incorporated strongly. Thank you.
Thank you very much. Our next speaker is Christine Cowley. Christine is a person with 33 years of living with a spinal cord injury. She has a doctorate in neurophysiology and is an assistant professor and director of the Spinal Cord Research Center at the University of Manitoba. She is a former wheelchair track Paralympian, current member of several community-based boards of nonprofit charitable organizations with missions to improve quality of life and health of persons living with disability. She lives in Winnipeg with her spouse and 3 children. Welcome, Christine.
Hello. I sustained a spinal cord injury in 1987 at the age of 20. After my injury, I received 3 months of in-hospital rehabilitation where I learned how to navigate the world as a person with tetraplegia, including how to manage all the altered physical functioning that comes with it. I was considered a model patient, returning to university while still in hospital. I had the support of dozens of friends and family and still do today. I left hospital, continued university, and began training to compete in wheelchair track. This then led to 3 medals and 2 world records in the 1992 Barcelona Paralympics. I returned to Winnipeg, got married, and changed my name from Harder to Cowley and took up my PhD studies and attained a doctorate in 1998. I became a mother of twins in 1999, and we had a 3rd child in 2001. I've traveled professionally and with my family throughout North America and Europe. I hand cycle extensively, including completing at least 1 marathon every year. To all outward appearances, I am a successful person living and contributing to our community. Before injury, I had never ever thought of suicide. It just wasn't in my repertoire of thoughts. But I would be lying if I told you I had never thought about killing myself when first injured. And I'd also be lying if I told you that I was good to go within 3 months of my injury when I was discharged from the hospital. In fact, it was several years before I was able to open my eyes in the morning and feel good. However, today I will tell you that my quality of life is excellent. I wake up in the morning thinking about what I'm going to accomplish today. I've lived a fulfilled life. I have a fulfilled life. One of the problems with Bill C7 is that currently it does not have safeguards in place to protect people from making not only an uninformed, but an unexperienced decision about dying without counseling or supports and in the early stages after severe neurological impairment. It's insufficient just to be offered those counseling or supports. It was necessary for me to reintegrate and experience community life. And lastly, one of the reasons I didn't seriously pursue suicide in the first 5 years after my injury was because it wasn't offered to me as a medical choice. Had it been, I might not be here today. Thank you.
Thank you, Chris. Our next speaker is Dr. Karen Ethans, who is another physician who specializes in physical medicine and rehabilitation. She has a subspecialty in spinal cord injury. She's an associate professor at the University of Manitoba and has worked for over 20 years as a clinician and researcher at the Rehabilitation Hospital at the Health Science Centre in Winnipeg. She is the service chief of the spinal cord injury program. Dr. Ethans.
Thank you. Good morning. As a rehabilitation specialist physician, I treat people with severe disabilities. I follow people with spinal cord injury from acute care through rehab, transition to the community, and lifelong follow-up to prevent complications and manage symptoms to help improve the quality of life of my patients. My recommendations I'm making today are based on my research and clinical experience of more than 20 years. Particularly concerning in Bill C-7 is the removal of the criterion of a person being expected to die naturally in the reasonably foreseeable future, which means that anyone with a significant disability may request MAID, and the waiting period proposed is only 90 days. While I respect everyone having autonomy, once being able to make an informed, independent choice for their care, I do not believe that people with new, severe, potentially permanent neurologic disabilities, such as spinal cord injury, will have the ability to make this informed choice until they've had the opportunity to have lived with their new impairments and disability, reintegrate into the community, and realize the excellent quality of life that is experienced by most with such disabilities. People must have the opportunity to live this experience before being able to make an informed choice on an issue so important as ending their life. I have seen cases where some healthcare providers do not understand that most people with spinal cord injury live a long and satisfying, productive life. And at times, these healthcare providers have reflected their uninformed opinion onto their patients. Many, if not most, people with new spinal cord injury, as we heard from Chris and Natalia, or other severe disability, at least consider at some point after their injury a wish to end their life or not go on. However, once having gone through rehabilitation and integration back into the community within a few years, these same people, for the most part, rate their quality of life high, and many, in fact, higher than that of the non-disabled population. Being offered MAID in that early period when they are vulnerable and don't realize the excellent quality of life their future may hold would be a grave failure to these patients. Thus, we should amend Bill C-7 to mandate that people with severe disability should only choose MAID as an option once having become informed of their future life possibilities by living that experience, which we know may take several years. Thank you.
Thank you, Dr. Ethans. Our last speaker today is Bill Adair. Bill is the Executive Director of Spinal Cord Injury Canada, a federation of organizations that assist people with spinal cord injuries to achieve independence, self-reliance, and full community participation. He is on the board of directors of Accessibility Standards Canada and is a member of Minister Qualtrough's Disability Advisory Group. He received the Meritorious Service Medal from the Governor-General of Canada in 2016 for his efforts to promote equal opportunity for people with disabilities in Canada. Thank you, Bill.
Thank you. With the proposed changes to MAID, Spinal Cord Injury Canada believes that we will lose many bright and creative people. The proposed safeguards do not allow the time and support required for people with spinal cord injuries to make an informed and uncoerced decision about medical assistance in dying. People with a new injury will not have an opportunity to maximize their potential recovery and receive enough information to reasonably contemplate their future before being allowed to consent to MAID. MAID promises each person the support and time necessary to make an informed, uncoerced decision. This promise is especially important for vulnerable people working on accepting life with a spinal cord injury. For a person to adapt, adjust, and ultimately thrive, they need the very thing this legislation will take away: time. They need time to mourn, they need time to absorb new information, and to organize and receive support. This time enables people to see beyond the initial pain, loss, hopelessness, and despair as they contemplate their future life. 90 days is not nearly enough time for this process to take place. We call on Parliament to amend MAID to provide a much longer adjustment period that allows each person to have supports in place and to experience life in the community before choosing death. Our second concern is that pain, discomfort, avoidable health complications, and suffering can be caused by a lack of supports and services when a person returns to life in the community. Living alone, financially strapped, and with no support could drive any one of us to choose to die. The significant disparities in services available across provinces and territories contributes to people losing hope for a satisfying life. This inequity is not in keeping with the principles of the Accessible Canada Act, our country's law that assures access and inclusion for people with disabilities. We call on the Minister of Employment, Workforce Development, and Disability Inclusion to include people with disabilities in discussions with provincial and territorial governments. Together, we can work towards equal access to resources and services in all communities across Canada. Nothing without us. Thank you.
Thank you, Bill, and thank you to all our speakers. I think we're finished now, so we will take questions shortly. I'd just like to finish by saying that Physicians Together with Vulnerable Canadians was a group that was started by a few doctors who wrote a statement, and now we have over 1,000 doctors across Canada, across specialties, who have endorsed this statement. So there are many of us who feel this way. And I very much thank our guests who did an amazing job from the Indigenous, disability, and medical communities to come forward and share their concerns with us. So now we'll accept questions. One question, one follow-up. We'll start with 3 questions on the phone before returning to the room. Operator, could we have a first question on the phone?
Yes, certainly. Please press star 1 to ask a question. Veuillez appuyer sur étoile 1 pour poser une question. And we currently have no questions over the telephone lines. Nous n'avons pas de questions au téléphone. Je vous retourne la parole.
Perfect. Are there any questions in the room? Okay, perfect. This concludes our press conference. Thank you very much. And thank you, everybody.
Thank you.